welcome to DEBAKEY CV Live. Today we have a special program focused on vascular surgery education. My name is Edward Andraos. I'm a PGY7 vascular fellow at Methodist Hospital.
And my name is Manny. I'm a fifth year, or going to be a fifth year, currently a fourth year, integrated vascular surgery resident at Houston Methodist.
And I'm Yusuf Chauhan. I am a second year going on to be a third year integrated resident at Houston Methodist.
We are honored to have with us a special guest panel from various programs throughout the country. First, we have Dr. Nawar Hudefi, PGY1 integrated resident at Baylor Houston. We have Adam Korayem, an integrated resident, PGY5 at Mount Sinai in New York City. And we have Dr. Sonia Talathi, second year fellow at North Shore LIJ, also joining us. Welcome, everybody.
Ed.
Great.
So let's start off with a brief introduction to this topic. So our topic today is the integrated versus the fellowship vascular training pathway. So a brief history on this topic. So vascular surgery has a long history, and the operation on vessels has a history that can be dated back centuries, all the way back to trauma, where vessels that were bleeding were ligated. However, the vascular surgery of the modern era, the vascular surgery that we know today, really kind of exploded in the 60s, and with many pioneers in vascular surgery at the time. But vascular surgery training in the 60s was not at all what we know it to be today. In the 60s, if you wanted to become a vascular surgeon, essentially you found an apprenticeship and you followed one of these pioneers of vascular surgery at the time, and you learned how to do vascular surgery. And essentially the vascular surgeons of the 60s were general surgeons or cardiac surgeons who had picked up vascular surgery along the way. And Dr. Edwin Wiley from UCSF in the 70s was pushing to get this changed. Him and a large group of people felt that vascular surgery needed to have a formal training, that it couldn't just be an apprenticeship model and you kind of pick up skills here and there and everybody's doing vascular surgery. He wanted it to be an official subspecialty of general surgery. And so in the 70s, there was this big push to make vascular surgery its own subspecialty. And with that, when the ACGME was initiated in the 80s, vascular surgery training was officially started as a fellowship program. And what that meant is initially it was a 5+1 model, meaning that people would do 5 years of general surgery and then would do 1 year of vascular. And things changed in the 90s, and what happened in the 90s was a huge change in vascular surgery. In the 90s, the endovascular revolution happened, and all these endovascular technologies came into play, and vascular surgeons could no longer be trained in only 1 year. And so in the 90s was kind of the official birth of the 5+2 model that we know today, where a medical student after graduating medical school enters general surgery, does 5 years of general surgery, and then goes on to do 2 years of fellowship to become a vascular surgeon. However, there was another push. In the early 2000s, there was a push within the vascular surgery community to separate from general surgery, in the sense that we wanted to become our own specialty, not just a subspecialty of general surgery, but vascular surgeons wanted to become a separate specialty in and of itself. And so in the early 2000s, vascular surgery was kind of accepted as a separate specialty. And the boards of surgery began to accredit a certificate in vascular surgery. And this kind of revolutionized the field, and it changed a lot of things. And one thing that it changed is that the fact that vascular surgery could now become its own specialty without the need for general surgery, it created this new training pathway, the 0+5 programs. And this 0+5 training pathway enabled people to go into vascular surgery directly from medical school without having to do a general surgery residency. The first approval of this training pathway was in 2007, and the first integrated vascular surgery residents started training in 2007. These first residents graduated in 2012. And one may say, why the incorporation or the birth of this integrated training pathway? The fact is that there were a few problems with the 5+2 training paradigm at the time, and one of those problems was that it was becoming more and more challenging recruiting people to that fellowship. And during those early years in 2000, a lot of the programs, the fellowship programs were going unmatched during the fellowship match. And largely this was because people, just didn't want to train for that long. A lot of people had increasing student loans, increasing debt, and many people just wanted to train for 5 years and then go on to practice surgery. And so because of those difficulties with recruitment, the thought was that if you could shorten training by a couple of years, and if you could recruit medical students early on, then you could increase the demand for vascular surgery, and that more medical students would then go on to become vascular surgeons. And this is very important because at the same time, while we were seeing decreasing number of applicants to vascular surgery fellowship, we were seeing a huge demand in vascular surgeons out in the community and in our country with our aging population and the effects of smoking on our population. So as our trainees were decreasing, our demand for surgeons was increasing. And so all of these changes happening at the same time were kind of the impulse to create the 0+5 integrated program. And today, this is a well-established training pathway, and the two pathways currently coexist. So if you want to become a vascular surgeon in the United States, right now, the two main pathways are that you do 4 years of medical school, and after those 4 years of medical school, you go on to do 5 years of general surgery, followed by 2 years of fellowship. Or you do your 4 years of medical school and you go into the integrated route and you do 5 years of integrated vascular surgery. And while these two pathways are now well established, I think the controversy remains, and there's still a lot of questions to be answered. There's a large debate that currently is underway as to the adequacy of training within the integrated program. So this first paper I want to talk about briefly is a paper published in 2014 in the Journal of Surgical Education. And basically what they did was a large survey of vascular surgery chairmen and Society of Vascular Surgery members. And they pooled this large survey of surgical attendings and asked them about their perceptions about trainees. And what they found was that at the time, only about a third of vascular surgery chairmen believed that the integrated residents would be as well trained as the fellows. Only about a third believed that they would be proficient in open surgical skills, and only about a third believed that they would be as mature as graduating fellows. That being said, greater than 90% of these pooled would be willing to hire an integrated vascular surgery resident. With this, a number of other papers then came out later. Next, in 2015, there was a paper that looked at the assessment of the operative logs, because there was this big debate about whether you could adequately train a vascular surgeon in 5 years and whether you could teach him to do open surgery. And so they looked and they compared the fellow logs with the integrated vascular surgery graduates and their operative logs. And what they found in this paper was that they were equivalent, essentially. That they had a similar number of open vascular cases. And in fact, the integrated residents had a bit more of the endovascular experience. Because they had more time on the vascular service, they had more endovascular cases. And the multiple other studies have also kind of shown this, that there's been an equivalence in the number of cases. Now, whether that translates to an equivalent in proficiency, that hasn't been proven and hasn't been tested. One thing is for certain, though, that doing 7 years of training is you're not going to have the same amount of open abdominal procedures as somebody who does the 0+5 program. There was a paper, if you go on a couple of slides, there was a paper that essentially looked at the open abdominal experience of fellows compared to integrated vascular residents. And what they saw was that if you go through general surgery, you do a whole lot more open abdominal cases. Now, these are not necessarily open aortic cases or open vascular cases, but you do a lot more open bowel surgery. And so one thing I think that is clear is that fellows coming from a general surgery background tend to have more comfort in the abdomen and just have more experience navigating their way inside the abdomen. So today we have a set of guests from different locations, and we kind of, in different stages of their training, we want to ask them about their training. So we want to start off with a younger guest today. So here we have Yusuf. He's a second-year integrated resident, and we also have one of our guests from Baylor, Nawar, and she's a first-year integrated resident. So we want to talk to them a little bit about their experience.
Yeah.
Before we do that, I just want to remind our viewers to text any questions to DEBAKEY. Text your questions to 37607. Text DEBAKEY to that number, and then you can text your question afterwards. If you prefer to go online, you can go to pollev.com/DEBAKEY and ask your questions there. Sorry, back to you, Yusuf.
So one of the first questions you get even when you're interviewing for integrated vascular surgery residency is, what made you want to become a vascular surgeon? So, you know, coming out of medical, there's an idea that if you complete general surgery residency first, you've had an opportunity to rotate on the vascular service and you understand what it's like to do vascular surgery. So one of the questions, and we'll start with Nawar, is what made you want to do vascular surgery, and what made you feel comfortable choosing vascular surgery as a subspecialty instead of wanting to do general surgery first?
Sure. So for me, I think I knew early on, starting my medical career, that a critical element of my career had to be some sort of fulfilling relationship with my patients. I think that's majority of students and anyone that goes into medicine thinks. And so I had kind of ruled out surgery from the very beginning, thinking that you operate on a patient, you see them once or twice post-op, and that was it. And that wasn't quite the relationship I wanted to have with patients. So I ruled it out, and then third year comes around. I was exposed to it early on in my rotations, and I saw that probably one of the most satisfying aspects of vascular surgery were the intimate relationships that were formed with patients and the physicians. So your vascular patients are, some of the sickest in the hospital. They have multiple comorbidities and their conditions are chronic. So you get to know them and their families, like I said, intimately. You get to be involved in their care throughout their lives. And so once I kind of recognized that and my perception of surgery, specifically vascular surgery, changed, I had great mentors, and I can't really underestimate the importance of great mentors at this point in my life. And so they were always there, just enthusiastic about my enthusiasm for vascular. They were there to answer my questions and really just available really at all times during my medical school career. So when you have your enthusiasm for surgery or vascular surgery and you have the mentorship, it really became a no-brainer at that point. That's what I wanted to do, and vascular surgery in particular. So like I said, a big part of it was the relationship with patients that I would get through vascular surgery, and then the cases. The cases are, they're cool. You operate anywhere in the body. You have your complex open cases, you have your complex endovascular cases. So again, no-brainer there. As far as why I wanted to do integrated, simply put, at the end of the day, I knew that I wanted to do vascular surgery as my career forever. I was exposed to a couple other fields, probably not as great of an exposure. I might get to rotate through all the vascular services, general surgery services. But I enjoyed general surgery. I enjoyed my time on the general surgery services. However, at the end of the day, I love the vascular OR. I love the vascular patients. And so for me, in making the decision on which route to take, it came down to which route was going to get me the most and the quickest access to vascular patients, to really just a vascular life. And for me, that was the integrated program.
Great, Nawar. So I think one of the biggest criticisms, or at least the comments that I've seen, is that how could you, in such a short time in medical school, experience enough in vascular surgery to be certain that this is what you want to do for the rest of your life? And the second part of the question, being that you're almost done with your first year, how have your expectations as a medical student sort of compared to the reality of vascular surgery as a career or as a resident?
Sure, that's a great question. I get asked that a lot. The whole, how did you know in 3 weeks' time on a vascular service that you wanted to do this? And it wasn't a decision taken lightly. So like I said, I never considered surgery in general until my third year. And so having, 3 or 4 weeks on vascular, and then having the time throughout the year to go to the vascular conferences, to attend lectures, to attend conferences, to meetings, to talk to my mentors. Can I say that I really fully understood the extent of vascular surgery as a third-year med student, or even as a fourth-year med student? I think the answer is no. It's hard to kind of understand or wrap your head around the scope of vascular. Even really as an intern, I'm finishing up my intern year, and there's still a lot more that I'm discovering. But I felt like I had seen enough. I had reached out to multiple surgeons in the field, in vascular and outside of vascular, to really feel like this was the career that I was going to be most fulfilled from. So I don't really know if there's really a good answer. I mean, how do you know? You just kind of, you just know. You go into, I don't know. I just knew this is what I wanted to do. And I really haven't regretted it. So the expectations as a med student, you think that you're going to start residency and you're just going to dive right in. You're going to be in the OR. And I think we can all agree that's normally not the case as an intern. But the one thing the trend that has kind of continued over from med school is the mentorship that I receive in my program. And I think that's true of many vascular integrated programs. And I don't know if it's because they're small programs. I have one resident. I'm the only resident in my program. Some programs have 3. I know Methodist has 2. And so the type of relationship and the acceleration of the relationship you have with your attendings is at a different level. And so that mentorship, I was surprised to find, developed quickly, even as an intern, that I don't necessarily think is true of my other colleagues in other fields, if that makes sense.
Nawar, question for you. When I remember when I was applying to integrated vascular surgery, one of the things I had, like you, I had vascular surgery mentors, and of course they were all from the 5+2 training pathway. So it was a little bit of a shock to them when I told them that I wanted to go into the integrated pathway, because they had all done fellowship, they had all done general surgery, and one of the things that they kind of brought up is this question of, are you going to be well trained? Like, this is the tried and true method, the 5+2. And so I got a lot of questions about, do you really feel like you're going to be able to train in the extensive world of vascular surgery within 5 years? And as I kind of looked at the literature and reached out to people, I think as a fourth-year medical student, the research that I did, I came up with the answer, yes, that I felt like I could be well trained and I could be proficient in all aspects of vascular surgery from an 0+5 program. Did you face that same opposition or questions when you were applying?
Sure. It wasn't necessarily opposition in my case, but I did have that question. I remember my mentor said, do you really know what the difference is between going, between these 2 routes? And I said, yeah, one's shorter, one's 5 years and one is essentially 7 years. And he said, no. And he pointed to his wall of diplomas and he said, the difference is that board that you see up there. And he goes, if I were to be doing an aortic case and I injure the bowel, I can fix it, and I can fix it well, and I can fix it comfortably. If you're going to go the integrated way, then you're going to have to be comfortable with not being able to do that. You're going to have to call for help. Are you okay with that? Essentially, he kind of gave me that little ultimatum, are you okay with having to call for someone in the middle of your operations to do that? And I obviously decided that I would be okay with it. But, I came from more of I came from an academic institute, but it was more rural. And so, your vascular surgeons did a lot probably more general surgery in their cases. And so being here in Houston, I still think that a lot of our vascular surgeons, even though they went their traditional route, should they injure the bowel or should some other complications arise, they would still call on our general surgery colleagues to help them, just because they're better at it. Not better. It's something that they do daily versus, what the vascular surgeons do, if that kind of makes sense. And so it wasn't so much of an opposition. It was just something that I had to come to terms with. Do I want to be able to fix the bowel or whatever it is that, I could be potentially injured during my surgeries, or will I have to rely on someone else?
All right, so thank you, Nawar. So involving Adam and Sonia into our conversation, you could see sort of from her standpoint, the calling to vascular surgery was one of passion, one of mentorship. And if I can have you both sort of chime in on, first ask you, Sonia, as a fellow general surgery resident first, then becoming a vascular fellow, how was your journey to vascular surgery, which I would assume is obviously not a direct one like Nawar's?
Right. So as a medical student, I knew I wanted to do surgery, but I came from a medical school with a very robust vascular program. And because of that, you only rotated on the vascular service if you chose it as a selective. Having said that, I never had any exposure to vascular surgery, other than what I had read in a book or some question I'd answered on a test. So I actually came into residency thinking I wanted to do trauma. And then early on, I rotated on the vascular service, and obviously I loved vascular. That's what I wanted to do. But I think, just to sidetrack, that's an important point. I think as a vascular surgery as a field, we really need to go to the medical schools and make sure that medical students are getting exposed to vascular very early on, since the integrated option does exist. And if that's something that they want to do, to know that's available. So then in residency, the more I got exposed to vascular, that's, it was my field, it's what I decided to do. My general surgery experience has been invaluable. So obviously I am not an integrated resident, so I can't compare directly. And either way, you have to come out well trained, otherwise the programs wouldn't exist. But it has helped me. I feel very comfortable, open. I feel comfortable taking care of patients. I was fine in the COVID ICU thanks to general surgery. But I really like the path I took because it really led me to fall in love with vascular surgery, all components of it. And then I could use my fellowship years to really focus on endovascular, because like we were talking about those papers mentioned earlier, I did not have as much endovascular exposure in my residency. So that's kind of how I...
That's a great point, Sonia. And I think just to echo what you're saying, I think your exposure in medical schools kind of haphazard. Sometimes some people get exposed to this field early on, some don't. And I know you did your general surgery at Montefiore, where they have a robust vascular surgery program there. And it's sort of that experience sort of helps guide you as my experience helped guide me into the field. Now, Adam, just to have you weigh in, you and I went to the same medical school, but you had a different experience and absolutely got convinced that vascular surgery was your field way earlier than me. Can you chime in on how sort of vascular surgery captured sort of your mind early on?
Yeah, absolutely. I have known you for a long time. Actually, the most vexing question I have is, for all this time that I've known you, it seems like your hair has gotten thicker since your training. So you'll have to tell us what the secret is for that, because it's been elusive to me so far. I would say I did a lot of research in vascular surgery. I spent some time in the vascular biology lab. I'd say for people, debating, one, find your subject material. Is it material that you're comfortable with, that you enjoy studying? I like cardiovascular physiology quite a bit, so I knew that I would lean that route. Find your tribe of people. The vascular surgeons in my medical school were all interesting and dynamic, and I really felt comfortable with them. So it was a group that I wanted to be part of. Do you like being in the operating room? Do you like that kind of teamwork environment? The vascular patients, they have chronic issues. Is that the type of patient you want to be with? They're usually very sick, and they demand a lot more from us than I think some of the other specialties. It's not too common that we have a healthy patient come that we're going to operate on. So all those things taken together, I think, can help guide whether or not vascular surgery is the right choice for you. Again, for me, it was a subject material. I really liked cardiovascular physiology. I liked blood vessels, and that sent it home for me. In terms of training, if I could just comment, I think, this day and age, there probably is no excuse if a medical student decides that they want to go into vascular surgery. There's so many resources. All of the societies, from the national, the SVS, to local societies. I'm part of Eastern Vascular, and they go through great lengths to, have programs. They have travel scholarships for students to get involved. So there's quite a bit of information and resources today that are available, for students. The problem is that they may not get exposed to it early on. So, that's the one disadvantage. My last point in terms of, which is better, the 5+2 or the integrated, I will say that I don't think there's, I think it's the wrong question. There isn't one, in my opinion, that's better. At Mount Sinai, we take a fellow every year. We work very closely. We certainly come from different places, but we all end up at the exact same spot. Some have, different strengths and weaknesses, but that's to be expected. I think the key is volume. And the people who are training you. If you have the volume and you have the right people training you, then I think you're going to, be successful regardless. As an integrated resident, you go to conferences, from an early part. You're thinking about doing these cases from an intern level. You're presenting. You're involved in research. You're seeing vascular patients on a daily basis. You're going to clinic. You're involved in the daily resident conference. So I think you just get a lot of vascular surgery early on. So. I think both are trained very well. The volume and the people who are training you is certainly key.
So we're going to turn our attention a little bit to these questions. We have a few questions coming in. One interesting question that came in earlier was about open AAA. So that's kind of been, when people talk about the difference between vascular surgery integrated programs and fellowships, it's always what comes up over and over is the comfort in the abdomen, the comfort inside the abdomen. And one thing that people kind of worry about is, are integrated vascular surgery residents going to be able to do open abdominal AAAs when they finish residency? And so the question that comes in is to that point, and it's saying, open AAAs, do you think that an integrated resident is more likely to suggest endograft or an EVAR with a marginal anatomy than a fellow? Meaning, if an integrated resident sees a patient that has the anatomy that may be marginal for an endovascular repair, would they more likely push those limits as opposed to a fellow? Would they more likely go with the open route? So I'd like to kind of turn that question to our second-year fellow and our PGY5 from Mount Sinai, Adam and Sonia, and kind of what your thoughts are on that.
I don't think necessarily a traditional fellow would lean more towards open. I think the answer to that question really is based more on who trained them in fellowship. Being more comfortable in the abdomen doesn't necessarily, or even if that's true, doesn't necessarily mean that you'll pick the open option more often. I really think it's a outcome of where you trained and who trained you, about which route you pick.
I think, number one, you have to do really what's right for the patient. So if you, want to do a complex endovascular case because, the patient may not tolerate open surgery as well, during your training, you're going to identify mentors and people that, you work with that can support you. So you're never, or you shouldn't be alone. If you are alone, after you graduate, then I think maybe you've done something wrong. But you've got support. You have people there that are there that can guide you, and I think doing what's right for the patient is by far the most important step. Whether it's open or endo, coming from my program, I can say I'm comfortable doing both.
So another question that we've been asked is estimate the cost saving by shaving off 2 years. Does this influence the decision? I can speak a little bit to that. It's one of those things that's there in the back of your mind. That's 2 years of salary income that for whatever reason you may be looking forward to. But I think ultimately it comes down to just wanting to do vascular surgery because you want to dive into what you're passionate about. The idea that, you'll be saving a bit of money, you'll be able to pay off your student loans a little bit quicker is nice. But again, that's something that's very much on the back burner. It's definitely not the decision, at least for me, that drove my decision to go into vascular surgery. Nawar, since you recently came into this, was that something that you thought about? I mean, every year medical school loans or tuition gets higher and higher. What are your thoughts on that?
Kind of agree with you. It wasn't so much about it wasn't so much about time you're already in so much debt and you already have so much to pay off. So it wasn't really, that didn't really play a big role in my decision. It was more about diving in, like you said, into something that you want to do. And I think it's important to know that there's still a lot of integrated programs that have research years, and so. Like my program has a year in there, so it's still a 6-year program, and there's some 7-year programs. So again, it's not so much about cutting the time short, it's more about just diving into what you want to do.
Makes sense. So at this point, we'll do one more question from the board, and then after that, we're going to take a little break, and we're going to have some attending physicians from throughout the country just comment on the same topic. So the second one question I want to address is a question from the audience. Let's do the next question, the first question. Okay, so this is, it doesn't say who sent it, but I found a passion for vascular surgery late. I realized it halfway through third year. Because of that, I don't have any publications, but I went to VSS 2020, found students with many applications. Can I still be competitive, and can I apply confidently? I think that's a very difficult question to answer, not knowing the full scope, and I think no applicant is just looked at based on their publication. But I'll defer this question to Adam. What do you think would be helpful tips for this medical student applying into vascular surgery residency?
Sure. I understand the concern. When I was a medical student, of course, you want to make sure, you've checked off as many of the boxes as you can. I would say not to worry. If you're passionate about going into vascular surgery, get involved in something. You don't have to have, a number of publications. If you have, any, that's great. That can only strengthen, but it won't, and not having any won't weaken your stance. If you are motivated, get involved in research. You can just explain that you came to it a little bit later, and I think that'll be okay. We've had applicants that have had many publications and were not a good fit for us, and we've had some with very few or none, and we're the perfect fit. So it's much more than one aspect. Publications do help. Try and get involved. At this point now that you have decided this is where you want to go.
Thank you. Dr. Sonia Talathi, Dr. Adam Korayem, Dr. Nawar Hudefi, thank you so much for joining us. We really appreciate having you on the program. And we'll take a short break, and we'll be back with a few attendings to discuss the matter further. Thank you.
Thank you.
The vascular masterclass in ultrasound is really designed to teach somewhat of the basics principles, but we emphasize much more the hands-on experience. In the DEBAKEY CV education programs that we run, we pride ourselves with the concept that we can deliver lectures to you anywhere in the world. We can do that using electronic media.
It has been an amazing course. Small groups, very approachable, very personable, and tons of great information. There's lots of information I can definitely bring down to our practice, to our physicians, and hopefully involve TCV into our daily practice
having the ability to talk one-on-one with the physicians in a small group, in a small room, and being able to understand and listen directly from them what's useful.
So we pride ourselves here in providing what we think is the premier hands-on experience. In order to do that, we need two groups of people to be vested in this. Number one, it's very important to us, and we're very grateful for the imaging vendors who bring in the latest and greatest technology and imaging equipment. But in addition to that, it's extraordinarily important that patients participate. We really want you to be scanning with known pathology, and we have a number of patients who very graciously agreed to give up their weekend, come in here, and be subject to applications for this new technology. So in that respect, we think we've got the best of all worlds. Very grateful patients with known pathology and the latest and greatest in imaging technology.
We are here to showcase our Accuson Sequoia for the sonographers and physicians at this conference. It's been a real pleasure being able to share our new technologies as well as showcase everything that the Sequoia has to offer.
Having the chance to attend the conference this weekend allows Board the opportunity to partner with Methodist and find new and innovative ways to bring products to the marketplace to help improve patient lives.
So I'd like to invite you to come and attend the next Vascular Ultrasound Masterclass. It really excels in having world-class faculty, the best technology that you can get your hands on, and patients with known pathology where you can get actual scanning experience and real-world interpretation classes. So please come and join us in Houston next year. Thank you.
Welcome back to the program. We have a few additional guests that came on during the break. First off, Dr. Alan Lumsden. He's the Chief of Cardiovascular Division here at Houston Methodist Hospital. We have with us from Miami, Florida, Dr. Micheal Ayad. He's the Associate Chief of Division of Vascular Surgery and co-director of the vascular lab there. We have Dr. Sara Edeiken, who is one of our new attendings working at San Jacinto here at Methodist Hospital, as well as Dr. Thomas Lowe, one of our new attendings working at the Woodlands Hospital branch of Houston Methodist. Welcome all to the program, and thank you for joining us.
Thank you.
So the first question we'd like to direct to Dr. Lumsden. So, as the chief of division here, one who is a huge proponent of integrated programs, has that always been your opinion, or has your opinion at all changed in years past?
Yeah, that's a great question. No, it was not my original opinion. I was not one of these guys who went, oh, this sounds like a great idea. I mean, obviously, I went through 5 years of general surgery and 2 years of vascular surgery, and there were multiple concerns. Number one was, how are we going to attract medical students to apply for this program? That was the number one concern. So, for example, we're all affected by our own experience. As a second-year resident at the VA, general surgery resident at the VA, the fellow said, hey, you're not bad. You should think about vascular. I said, I will never do this specialty. I found the patients confusing, couldn't tell how many legs they had. They all had diabetes, COPD. I found it very difficult, at junior resident level, and I did not want to do vascular surgery. I want to be a trauma surgeon, and having a lot of trauma experience, I realized that things they were having trouble with the big vascular injuries. That's why I did the vascular fellowship. I was planning to be a trauma surgeon. Fortunately, a little more exposure in trauma took me away from that. So, but the message was, the fun part of the experience is backloaded in vascular surgery. You don't really tend to get involved in the technical aspects. You get overloaded with all the really difficult medical management components early on. And so that was a major concern to me, was not, can we get people trained? It was, how are we going to attract people to apply to this specialty, because there's so little exposure. I would fast forward, I'd say I was wrong. I think that this has been a transformational experience for vascular surgery, largely because we got you for 5 years. And the number of people in our program, this used to be a 1 or 2 person, trainee per year. Now, we've got how many, 13 or 14 people. And so it's a different experience, actually. It's great having so many people around. But I can tell you, pretty traumatic as we go from having a group of attendings who train. So, for example, cardiac surgery is not ready for this experience here quite yet. But given fully trained general surgeon, all we got to do is
train them in vascular, to here's a medical student, now you're responsible soup to nuts in teaching this person how to be a surgeon. That's a very different set of demands on the faculty. But however, I think we've all figured out how to do this, and it's worked extremely well.
Okay. If you can pivot this another question to Dr. Ayad. So, from a position of training integrated residents, Dr. Lumsden, Dr. Ayad, you are in a position where you're training general surgery residents, and you have the difficult challenge of attracting them or at least increasing their interest in vascular surgery. And that's a very difficult thing to do, especially that vascular surgery is becoming more and more esoteric. Tibial work is not as exciting to a person that wants to do colorectal surgery, for example, as it would be for someone who's dedicated in vascular surgery. So can you tell us a little bit of your tips and tricks to get general surgery residents interested in the field, and how you've done that at Mount Sinai in Miami?
Well, truthfully, that's a lot of times people know. There are some people come into residency with a presumption that of what they want to do. Once you come with a preset mind, I found it surprisingly, these are the ones that you can actually change your mind easier than the ones who are kind of don't know. Because a lot of times people come with a predisposed notion about vascular surgery that is primarily nowadays just wires and catheters and balloons and nothing else. And once they kind of rotate with vascular and see that no, we still do open aortas at times, open bypasses, and you establish a relationship with your patient, that kind of something that's a bit more unique to vascular compared to other specialties, and that these are your patients for life. You're not going to see them do their hernia, do their appendectomy or gallbladder, and then you're never going to see them again. They're going to come see you. They might bring their spouse, their kid, when they're older, what have you, or their parent or their aunt, and there is a bit of more personal bond that you don't get with, say, colorectal or general surgery. I do think that there are few things that you can extrapolate from general surgery to vascular, especially from the 5+2 aspect, because I think if for the zebras type of cases that you do for vascular surgery, that the techniques that you learn in general will help you. But I think, truthfully, I don't think that you need the 5 years of general surgery to be able to be a competent and adequate vascular surgeon. I think it's a different way of thinking that probably maybe 5-10 years from now, I don't know if we'll have 5+2, personally speaking.
Dr. Edeiken and Dr. Lowe, we'd like to kind of turn our attention to you. And you both are recent graduates. So Dr. Edeiken graduated from Albany, a place where they have both fellowship and integrated programs. And Dr. Lowe graduated from Houston Methodist, where we also have both the fellowship and the integrated programs. So I'd like to start with Dr. Edeiken and see kind of what your experience was in training, what the relationship between the integrated and the fellows were, and what your thoughts are about the two pathways and your journey to vascular surgery.
Yeah, so I think so I'm a 5 and 2, and I didn't do my general surgery at Albany. I came in there as a fellow. I did my general surgery in Chattanooga, Tennessee. And so it's sort of a two-part question, but in terms of the relationship between the residents and the fellows, at least where I trained, we basically treated, for fellowship, the 4th and 5th year residents were considered fellows. They were treated the same as a 1st and 2nd year fellow, respectively. And so, and then, when the 1st through 3rd years would rotate on the service, they were sort of seen as the senior resident on the service, regardless of what other residents we might have on the service. We sort of expected a little bit more out of them maybe than we would of one of the general surgery interns, for example. But it was, the expectation is that it was a cohesive group, but otherwise that the service was run by the fellows, and the fellows would inclusively mean both those that were 5 and 2, and those were that like a 4th and 5th year integrated resident. So that's my personal experience. And then where I trained for residency, we only had vascular fellows, so it was obviously different.
And Dr. Lowe, so talk a little bit about your journey in the integrated route and your experience with fellows, as well as a little bit about being a year out into practice. Do you feel, if you could go back, would you have done maybe general surgery? Would you think that additional training would have been helpful coming from the integrated route?
Yeah, so for a little bit of context, I was the first, or one of the two first residents to come into the Methodist program back in 2012. And would I go, if I could go back, would I do it any differently? There's no way. There's so many parts to the questions you asked, but really what I can distill it down to is my experience was pretty much identical to Sarah's, right? The way we did set up our service, very similar in terms of the 4s and 5s integrated, functionally very similar to how the fellows are. That took a while to get kind of sorted out in our program. That was an evolution. Every year it seemed to change. It felt like only the last couple of years it really solidified. And that's just because, again, I was the first class. I wasn't the first graduate because I did 2 years of research. But it took a while to really get that ironed out. But I think transitioning to kind of going into practice, what I realized very quickly was what Dr. Lumsden, Dr. Peden, and others echoed to me over and over again. The operating part is generally the easy part. That it's everything else that's very, very challenging. And you can come up with a laundry list of all the things that you wish you had more time doing. It's rarely, honestly, sometimes it is, I wonder what they were doing, and if I can plug the, DICET and CV educate. I mean, I did a femperineal bypass, but you can go onto the DICET website and you can look at all those operations again, refresh your memory and all that. And I did plenty of training, feel very comfortable with that, but no one tells you how to manage an office. Nobody tells you how to build a referral network. Nobody talks to you. I mean, you get little bits here and there. And that's where, honestly, I felt like my integrated residency helped me and prepared me probably a little bit better, actually, because I was in this space for longer, right? It was figuring out what referring doctors wanted a lot more. I mean, figuring out what a nephrologist wants for 5 years, kind of day after day after day. It's the same kind of pathology over and over and over again. So you build up that, and it's, I think, harder when you come in as a senior, either a fellow or resident, to try and learn that, because you're learning all the vascular part in terms of how to operate, how to do the operations, and also set up all these other things, as opposed to just taking on all the consults as the primary person, hearing the consult and figuring them out from the get-go, and interfacing with the community and all that. And I think that when I look back, it, like Dr. Lumsden said, it's the patients that are so complicated that make this a very challenging field. And the more exposure you have to that aspect of it, the better. And I mean, at the end of the day, it's on the individual more than anything, probably program secondarily, and the training paradigm third. I really firmly believe that. I think if you're at a good training program with both fellows and residents, you're going to get good training. But that's the biggest thing, is that there's more time, kind of soup to nuts in terms of the medicine, really, I think, makes a big difference, especially when you're out a little bit kind of on your own and you don't have as many of those ancillary services in a community hospital.
Thank you, Dr. Lowe and Dr. Edeiken. Sorry, were you going to say something, Dr. Edeiken?
I was going to say, I just, I largely agree with Thomas that it's less about the training paradigm than I think it is about the training in general. I personally, I think it's normal to all be a little bit biased towards our own training pathway. I wouldn't give up my general surgery training for anything, and the experience of having a chief service and a chief year. That doesn't mean I think that my colleagues who are integrated trained are not as well trained as I am. I just think that who I am as a surgeon was so well formed by the time I even came into fellowship that I personally would not either go back and do it again. I would do it again the same way I had done it, is what I'm trying to say. So it's more about where you train and what you take away from it than whether you do it as a fellow or a resident.
That's a great addressing Dr. Edeiken, and actually that's something that shadows my next question, which is I think you both kind of answered already, which is if you had to do it all over again, knowing what you know now, would you still go through the general surgery program? And I think Dr. Edeiken, you answered that. I am personally very proud of my general surgery heritage, and perhaps I had quixotic expectations that I was going to do general surgery next to vascular, which doesn't seem like a realistic expectation now. But if I can have Dr. Lumsden, Dr. Ayad, and Dr. Edeiken weigh in on, is that something that you thought about, at least in the beginning of your career, or at least during fellowship, that you would be able to do general surgery next to vascular? Is that a realistic expectation, or not so much?
Yeah, probably not so much, but it depends on where you practice. At the end of the day, and that's one of the dilemmas, and I do think if you've decided early on that you're going to practice out in the community, I mean, I'm not just talking about the suburbs of a big city, way out in the community, absolutely I think you're going to do general surgery, and I think it'd be crazy to go up the integrated route if that's really where you were going to be. It's easy in the big centers to, this was described to me, I did a rotation in Africa, and they said, one of the problems with training is that we cut the pie into vertical slices. What you need in more rural areas is to cut the cake horizontally. You may need somebody who can do a hysterectomy, you may need somebody who's going to do a gallbladder, and you may need somebody who's going to do a lower extremity thrombectomy. So I think if you know where you want to go practice, then I would tailor that choice based upon what I'm going to do. And so, would I change it? Yeah, if I knew it was going to be a vascular surgeon, I wouldn't do general surgery again. I come to Manny here. Manny's, we're now training the cardiac surgeons of the future. And so this is another consideration. I think the integrated vascular program will transform cardiac surgery. I think if you want to be a thoracic surgeon, you should do general surgery and then thoracic surgery. I think if you want to be a heart surgeon, you should do vascular before you do cardiac. And I think that one of the things that's not been figured out in the vascular surgery world yet is that people like Manny, people like all of you are highly, highly sought after in cardiac surgery, because you can now train for 7 years and come out fully trained in cardiac and vascular. So I think if you've got these predetermined notions, you're going to go work out and way out in the periphery, or you want to do heart surgery after this, then I would tailor my training choice based upon things like that.
Yeah, so like I said, to add to that, I mean, I think there are certain situations where someone might be more suited to the 5 and 2 versus the 0 and 5 pathway. For me personally, first of all, the integrated pathways were only first coming into existence when I was graduating from medical school. And I also didn't have a good enough exposure to vascular in medical school to even really consider that as a choice. So, and I came to vascular late. I actually really, didn't make that decision that I wanted to do that until I was probably in my, third or even fourth year of residency. So unless there's a way to really standardize exposure to vascular surgery in medical school so that everybody really gets a reasonable exposure to it, I think it would be hard to, get rid of the 5 and 2 pathway entirely, because there's going to be those people who really just don't get that exposure. And I think that's important, because that's a whole cadre of great candidates that we would miss out on just because they didn't know it early enough.
Yeah, but before the others chime in, let me echo. So even though I think the integrated program is going to be the way of the future, we will not get rid of the fellowship program, because I don't want to be excluded. I would hate to see the really good people who decide later on are going to go to our competition in the medical center. We want to be able to attract people who are motivated and very capable to come into vascular surgery. So I think it's great that we've got both of these training paradigms, and I don't think we should get rid of either of them.
Hey, personally speaking, I would not do it any other way. I would not go with a 0 and 5, not because of any lack of training in the 0 and 5, but rather because there are certain things I learned as I went out and started practicing that I felt my general surgery background helped me for these very rare and unusual cases. I don't practice any general surgery. I felt that vascular disease is so complex that I either try to be a good vascular surgeon or kind of okay general and vascular. So I just chose early on that looking for jobs, even if general surgery is required, that was not the job for me. So that's one aspect. It is not the practice of general surgery that I kind of that I seek. I think that, like I was saying earlier, some of the very uncommon cases that we encounter in vascular disease that maybe it's going to be once or twice in your entire career, I think that's when the general surgery exposure comes in very handy. A case I shared, just as an example, I shared with Edward the other day. We're doing an open resection of a pancreatic duodenal aneurysm. And truthfully, I have not done that before, not in fellowship. And it was really the general surgery training from that Whipple case exposure that I was able to kind of utilize for how I went about exposing that aneurysm and treating it. So these kind of cases, which is really going to be maybe at most, I would imagine about 5% in your career of the case volume you encounter. That's where I feel that general surgery training comes in handy and useful. But from the bread and butter vascular surgery, I think whether you go 0 and 5 or 5 and 2, you'll come out very competent.
Thank you.
So hearing those answers reminds me of a question that I had a lot when I was interviewing and trying to figure out whether I wanted to do integrated or the 5+2 route. For the more senior attendings, does it make a difference when you're making a hiring decision?
You're looking at me as the more senior attending. No, the answer is no, it doesn't make any difference. I fundamentally believe, said earlier, it comes down to the person. And I found it highly reassuring after we'd graduated several integrated that they could operate. There's also been others who are not quite as confident. But I think, when we come to hire people, it's all about the individual, their motivation and their background and what they've been trained at.
Question to Dr. Lowe. You've chosen a very non-traditional path. So looking at sort of the studies, there's one from USF that just kind of remarks an interesting statistic, is that more residents from integrated programs end up pursuing academic careers more so than private practice careers. And there could be speculations on why that is. Now, you were, I presume, ready enough out of residency to be able to be out on your own in the woodlands, and you were taking on pretty big cases. I have to admit, I was looking at the cases you were doing, and you're doing big cases, and you don't have a lot of help out there. So, can you talk a little bit to us about your readiness coming out of residency to be by yourself on your own taking on these cases?
Yeah. So first and foremost, I'm not on my own. Let's make that abundantly clear, right? I mean, I'm still within the Methodist system. I probably talk to the staff down in the medical center at least a couple of times a month. Sometimes it's running cases. Sometimes it's just talking about service things. But I have, and this is something that I wanted to talk about a little bit, is we overlap with a lot of specialties. So I have a fairly senior cardiac surgeon in our hospital that was doing a lot of vascular before I was here. I mean, in our community, the cardiac surgeons were doing the lion's share of vascular surgery, and they're more than happy to give up, honestly, a lot of it. But he's around it. When I do a big case, at the minimum, I am going through it with him, just as I would tell anybody graduating, whether you're a graduating fellow or resident, you have to have good partners that you can lean on and be able to at least go through things with, if not assist you in those procedures. Because it's very different when it's your name on the chart compared to being a resident or a fellow in the case. And there's a pretty senior cardiologist that, frankly, I'm not ashamed to say that. I mean, when I do complex endo things, he's far and away one of the leaders in this community as far as limb salvage. And honestly, his mentality is sometimes even more conservative than the way that we did things in vascular surgery down the medical center, which sounds, again, crazy sometimes, but honestly, it's been a very good working relationship, and I can do bigger cases because of that. I can take on more complex things early because I have that support. And I had the original idea of coming out here, which is about 40-ish miles outside of the medical center. And if I had big cases, I'd bring them down to the medical center. But frankly, we have a very well-staffed ICU. I have a lot of critical care support. I have a lot of nursing support that I wasn't necessarily expecting. I have, again, senior partners that are more than happy and willing to work with me and coach me and help me and mentor me through these cases. And so Without that, I don't think it would be possible, and I would be much more gun shy to taking those on. But again, that's why your mentors don't have to be vascular surgeons necessarily. We overlap with a lot of people. I mean, I had written down I overlap with general surgery, orthopedics, plastic surgery, cardiology, radiology, interventional nephrology in my area. And as long as you're willing to collaborate with those individuals and learn and bank on their expertise, I wasn't expecting, for instance, to do carotid stenting. We didn't do a ton of it in training, but I do a handful a month now, but always double scrubbing with one of our neurointerventionalists or one of our neurosurgeons. And that's been a very good relationship because, again, I learned things that I had a robust neurointerventional experience with Dr. Diaz and Klesnik downtown, but it's nice to have, again, those expertise local to allow me to really wade into it quickly and then take off.
Thank you.
If I just can add to that, I agree with Thomas. I mean, one of the things that one of my senior attendings and fellowships said frequently was, vascular surgery is a team sport. You do not want to be out in the middle of nowhere by yourself, especially when you first start with this, because, one of the things that some of us really love about vascular surgery is you kind of never know what the day is going to throw at you. So I benefited in my training from having really the gamut of experience. We did rural surgery rotations in my residency, and I rotated with a general surgeon who did general and some vascular. He wasn't doing complex vascular, but he was certainly taking care of the dialysis access and the bypasses and things like that in the area, because it really was truly a rural community. Versus the major tertiary referral centers where I did my general surgery in my fellowship. So I was able to sort of see those different practice environments and get exposure to that. I think that you can still do general and vascular if you're in one of those very rural communities, because there really is a need for it. Those people otherwise would have to travel an hour, hour and a half, 2 hours to get to see a vascular surgeon. And I think that's probably not the best for those people. So it really depends. But if you're going to be closer to a larger city, I think, I loved a lot of things about general surgery, but I did not love intercutaneous fistulas or sacral decubitus ulcers. So I decided that vascular was a better way to go.
I think those are all really great points. And it kind of alludes to the bigger point of your training does not stop after you're done with fellowship or residency. And this whole notion that if you do the 0+5, after 5 years you have to be competent in doing every single aspect of vascular surgery, or if you do the 5+2, you have to have everything worked out. This is a kind of a false premise, because vascular surgery is such a complex field that training really is a lifelong endeavor, and you learn every day as you go, all the way until the point that you retire. And so having those mentors, like Dr. Lowe and Dr. Edeiken alluded to, having those mentors and having those people that are going to continue training you even as an attending is just key and the key to success, I think.
Good point, and lifelong indeed. So now we're just going to direct our attention to some of the questions that are coming to us through the chat board, and then we'll sort of ask our guests some of these questions just based on what applies. So Yusuf, you want to take us through some of the questions?
Sure, yeah. So quick fire questions. First one, I know Dr. Rojo here is actually doing a cardiac surgery fellowship after doing integrated vascular residency. Someone asked, can you do a burn fellowship from the integrated vascular residency?
That's a great question, and we may have to look into that. But from what I understand is that burn fellowships, like critical care fellowships, can be done pretty much coming out of any training paradigm. So you can actually do critical care coming from vascular. You can do burn, I believe, also coming from vascular. Now the question is, would you be well prepared to go into burn? Not having that general surgery experience, and I don't think that I'm qualified to answer that question because I don't have an extensive experience in burn. But I think logistically you can. So out of vascular surgery, like Yusuf said, you can do a cardiac surgery fellowship, which I'm doing, and you can do critical care, you can do palliative care. There's a number of fellowships that can be done out of vascular surgery.
Okay.
Next question. Do you feel like there is a bias against DO students who are interested in the integrated pathway? This is open for anyone.
Yes. The short answer is yes. And that's not exclusive to vascular surgery. That's kind of across the board. There's always, or not always, there has been a longstanding bias against DO applicants in the standard match. I think it's softened over time, and certainly at the end of the day, like Dr. Lumsden said, in terms of faculty, it's the same with students, right? If an individual has reasonable board scores, and aptitude and interest is a big one, at least from listening into our meetings as far as bringing in residents, it plays a factor, but it's far from the only. I don't know, Sarah, if you were exposed to that at all up in Albany, or?
I can't say that we were too exposed to the sort of discussions that went on when considering DO applicants for the residency. I know that they had a DO fellow before me, there. So I think it's going to be program dependent. I know that, in my participation here at Methodist in the residency interviews, at least when I'm considering, a candidate after we've interviewed and we go and we talk about, all of them, whether they're a DO or an MD makes no difference to me. But I obviously am not involved in the initial stages of selecting who comes for an interview and things like that. But, I agree with you that there is some bias that's been there historically and that it's softened, but I agree that it's still there. Whether or not it should be or not, I think I don't necessarily agree, but, I'd have to defer to other people with.
I will also say, once I got out here, I can't tell you the number of times where I didn't know someone had been through DO, and I would have no idea. They're my anesthesiologist, they're my emergency room physician. It has no bearing on our practice. If they're a good physician, they're a good physician. If they're reliable, they're reliable.
Yeah, it matters not at all at the attending level.
Okay, next we have the next question is a pretty controversial one. So how do you feel about the overlap in endovascular procedures with other specialties such as IR and IC? And then can you scroll up just a little bit, please? Do you feel like push for minimally invasive procedures and endovascular procedures means patients would be less likely to see a vascular surgeon and see an interventionalist instead? Dr. Ayad, Dr. Lumsden, can you both sort of comment on that topic? And
Dr. Ayad, do you want to go first? You need to unmute.
I think
Dr.
you're
Ayad,
muted,
you need to
sir.
unmute yourself.
Sorry about that. Down here in South Florida, it's very different in that there is every other corner there is an OBL run by some interventionalist, and there's a lot of things that get done that maybe even the IC and IR guys in our hospital sometimes question. So I think that question is not really a very clear cut, or there are different aspects to it, meaning it comes down to the physician, right? We have very good relationship with interventional radiologists who do some peripheral work in our hospital, and at the end of the day, they do the right thing by the patient. Whether it's, they're not going to stent tibials unless it's something that's, must be done. They're not going to burn a bridge, and they will ask vascular to be involved. But you go out and there are certain, people with vascular surgeons or other interventional specialties that would kind of go in and stent everything, and regardless of whether that's the best outcome for the patient or no. So I think it comes down to the physician that you're working with, and I think as long as you have a good relationship with the team that you have with you, whether it's interventional cardiologist or radiologist, and you have an understanding that, look, we got to work together towards the best outcome for the patient, I think it really works out, because they do bring a certain set of skills that maybe we don't have or we don't get exposed to in our training.
Yeah, it's a great question. Now, I'm old enough to remember that in my fellowship I did 0. We took this away from interventional radiology. And we did that because we controlled the referrals. And so I'm always intrigued when I hear vascular surgeons complaining about the cardiologists taking it away from us. We took this entire thing from another specialty because we trained and we started controlling the technology and we controlled the referral pattern. So I don't have any problem with other people and other specialties doing this as long as they do the right thing. The problem is when they do the wrong thing and there is no supervision inside that specialty because frankly they don't necessarily know the difference. And so that's a problem. Do I think that it'll affect referral patterns for patients? Yes, it will, as long as we basically, there was a big debate in the vascular surgery world, should we change our name? Should we become vascular specialists? Well, surgery has a certain value to it. I mean, we're not surgeons, and so the decision was made that we weren't going to get rid of that. At the same time, however, we do have to produce that image that we can do all of these things. And just because you come see a vascular surgeon doesn't mean to say we're going to do an operation. So that's a continuing image challenge that we have. But you know, we can master that. I don't know too many vascular surgeons who are starving to death out there. Our specialty is growing like crazy. And I think it will continue to grow like crazy. And so the more people who are doing the right thing, if you talk to somebody in the know, like if you talk to a rep, for example, and they have a family member with an SFA occlusion, you know, they're going to bring that patient to the vascular surgeon because they know they want the right thing done. And so that's what we have to continue to emphasize, that we're going to do the right thing for you, not the quick and easy thing. But we are equally comfortable with the minimally invasive intervention as we are with the open intervention. It's about communicating that to the patient.
So doing the right thing by the patient, I think, is the common theme here, and that's something that we always strive to do, and we certainly definitely support colleagues who do the right thing by the patient as well. So in that breath, this is coming to our conclusion of the show. We're about 15 minutes over, but we wanted to give one last chance for any closing remarks. Dr. Lumsden, Dr. Edeiken, Dr. Ayad, Dr. Lowe, we really appreciate having you on, but I would like to give you the opportunity to close with any remarks that you have about the vascular 5+2 versus degraded program.
Personally, I think they both work well. We're wedded to continuing this. And I think I don't want to get rid of the fellowship because many people will decide late that they want to be a vascular surgeon. We certainly want to keep that open.
I just want to echo something that the rest of the group had said, is that just as important as you choosing vascular as a specialty is choosing a first job, whether you're out of 5+2 or 0+5, where you have mentorship, because that first mentorship can help you be on the right path for the rest of your career, and it's very important.
And the only thing I would add to that is it's all about volume and training. Mm-hmm. You have to see a lot of patients. You have to take care of a lot of sick people in order to learn how to do this. And it comes down to the individual, but the training program, whether it's 5+2 or 0+5, it's just about the volume of patients that you're going to take care of.
Yeah, I think it's about volume, and I think it's about a program that, understands that there's a difference between training residents and training fellows. And while you can train them concurrently, they certainly require, a different hand in training each of them. Versus one's a fully trained surgeon who's coming to you sort of for a vascular finishing school, and then another is someone, as everybody has said, soup to nuts, is going to need a lot of support in those first 3 years. And just, people that have the experience to train both residents and fellows, as long as you have that and the volume, as Thomas said, then at the end of the day, you're going to be a vascular surgeon.
Great. To our guest panelists, it was a pleasure having you on. To our viewers, thank you very much for watching. We hope you enjoyed our broadcast, and we'll see you next time on DEBAKEY CV Live. Thank you.
Thank you.
Thanks, guys.